session. We are going to talk about the liver function, and we would try to correlate some of the functions of the liver with the liver disease and how the liver disease is going to present. Uh, so what I'm going to do in this session is that I would start with some of the major function of the liver, which is the production of bile. So we'll just go through how the bile is produced, and then how it is stored, and what happens, why bile is important. So we go through some basic physiology of bile. The second half is going to be more on bilirubin, and then the third part is going to be what are the other functions of the liver, and we are going to talk also relate the function of the liver with the liver disease. So bile, as you know, is secreted by the hepatocytes, and normally bile acids and water are secreted by the hepatocyte, and they are modified by the cholangiocytes, which line the ductules of the hepatic ductules. And what happens by the modification of this bile is by addition of bicarb and water. So, the bile acids which are secreted by the hepatocytes are, modified by the cholangiocytes, which line the ductules here, and the bicarb and water is added. Then what happens is normally the sphincter of Oddi is closed, so this bile cannot pass from the biliary apparatus into the duodenum. So it goes back and it gets stored in the gallbladder, where it is stored, not only stored, but it is concentrated by the absorption of sodium chloride and water. So the bile acids which you see, which are released by the bile, which is released by the hepatocytes, is different from the bile which is there from the gallbladder, because it is more concentrated with more bile salts, as you see. And then when you take the meal, there is contraction of the gallbladder and relaxation of the sphincter of Oddi, which allows the bile, which is stored in the gallbladder, to go into the duodenum. Now, why these bile acids are important? The importance of these bile acids is that they are important in terms of emulsification of lipids. So it helps pancreatic lipases to act on the lipid molecules to digest them. The other important thing which the bile does is that because it has more bicarb content, so the acidic kind which is coming from the stomach gets neutralized because of the bicarb which is present within the bile, which, as we said, is modified bile, which is secreted by the hepatocytes, include bile acid, but it is modified by the cholangiocytes by addition of bicarb and water. Now you can just see this table and can make a, you can appreciate the difference between the bile which is secreted by the liver and the bile which is concentrated by the gallbladder. You can see that bile salts here are 1.1 grams per deciliter, but they are concentrated in the gallbladder to 6 grams per deciliter. And if you look at the sodium content, because most of the sodium is absorbed, the sodium content of the gallbladder bile is much less to what you see in the liver bile. And similar is the case with the chloride. But at the same time, you can see, that the bicarb content of the bile, which is secreted by the liver, is much more as compared to the gallbladder. And you can also see the difference in the pH. Now, first we need to see what are the bile acids and how these bile acids are produced. So we said that bile acids are produced by the hepatocytes, and the primary molecule from where the bile acids are produced is cholesterol. So what happens is that there is 7 hydroxylation and addition of the carboxyl group, which you can see here. The carboxyl group is added, and then there are hydroxylation which is happening, which results in formation of the primary bile acids. And these primary bile acids are cholic acid and quinodeoxycholic acid. Then in the hepatocytes, there is conjugation of these primary bile acids with glycine and taurine, and this increases the water solubility of these bile acids. And because these conjugated bile acids, they can easily become ionized, so they can bind to sodium and potassium to become bile salts. So you can see, and all this is going to increase the water solubility. Addition of hydroxyl and carboxyl group increases the water solubility, and conjugation of these primary bile acids with glycine and taurine is also going to increase the water solubility. And because once the bile acids get conjugated, they are easily ionizable, and they can easily bind to sodium and potassium, forming salts. But you must remember that hepatocytes only synthesize, conjugated bile acids. So unconjugated bile acids you don't see from the secreted by the hepatocytes. Hepatocytes only secrete conjugated bile salts or bile acids, which are conjugated with glycine and taurine. And because these compounds are ionizable, they can easily bind to sodium or potassium, giving rise to primary bile salts. Now, once the bile reaches the ileum, what happens is that there is deconjugation. That means the taurine and glycine, which is there, is being removed, and there is dehydroxylation, resulting in the formation of the secondary bile acids. And these secondary bile acids, because you have removed the hydroxyl group, they become deoxycholic acid and lithocholic acid by the action of bacteria. So the action of bacteria in uh, in the ileum and the colon will result in two things. One is deconjugation, which is the removal of glycine and taurine, and the other thing is the dehydroxylation, resulting in the formation of the secondary bile acids. And these secondary bile acids and then are passively, because they are not anymore water soluble, they are absorbed through the intestinal wall, returned to the liver to get reconjugated and resecreted. This is a diagram which is telling you, bile salts are important because they form the micelle formation, and this micelle formation helps the lipid molecules to get soluble and can be, then acted upon by lipases from the pancreatic enzymes. What you are seeing here is the normal mechanism and storage. Why bile is stored in the gallbladder? The reason is that there is, at normal time at rest, when you are when you are basically not eating, the sphincter OD is closed, and there is a pressure of somewhere around 30 millimeter of Hg, and that's why the bile which is coming down has to return back and stored into the gallbladder. So 75% is stored in the gallbladder, and 25% enters into the duodenum periodically on opening of the sphincter OD. As it opens periodically, it allows the bile to go into the duodenum. This is we have talked about, the concentration differences between the bile which is produced by the liver and the bile which is produced by the gallbladder. Now, how does the unconjugated, we said that in ileum and the colon, what is happening is that there is deconjugation, and there is also dehydroxylation, which happens by the bacteria which are present in the ileum. And 90% of the deconjugated and dehydroxylated secondary bile salts are being transported through the portal venous system back to the liver, and 5% from the colon, and only less than 5% of these bile salts are excreted through the feces. So most of it is returned back. Only 5% is excreted through the feces. So you can imagine if you have a problem with the small intestine and you remove the small intestine, you would have deficiency of bile salts, because then you would not be able to absorb, especially the terminal ileum, which is important in absorption of 90% of these bile salts. And you can see this in this figure, the mechanism how they are absorbed. So there is a co-transporter on the lumen of the intestine where sodium and bile salts are co-transported into the intestinal wall. And then, there is an exchange which is happening between the bile salts and the anions at the basal part of the intestinal wall, through which the bile salts enter into the portal venous system, into the blood, and then they are taken back to the liver. Now the regulation, how the gallbladder contraction and relaxation is controlled. So the major controller is the CCK, cholecystokinin, which is released by the eye cells in the response of the hydrolytic products of food. So eye cells are present in the duodenum. So once you have this hydrolytic products of the food digestion, which is lipids, the CCK is released by the eye cells. And then what happens that this CCK interacts with the receptors in the gallbladder and also receptors here at the sphincter of Oddi, which allows the relaxation of the sphincter of Oddi and contraction of the gallbladder. But the major mechanism we think now is neural mechanism. What happens is that CCK, which is released, is going to the affect the receptors, the vagovagal. It would generate the vagovagal reflex, which is going to stimulate the vagus nerve, and the vagus nerve through its efferents is going to affect the gallbladder through the acetylcholine, and similarly it is going to affect the sphincter of Oddi by releasing the neurotransmitter, which is the nitrous oxide and VIP, vasoactive intestinal peptide, which relaxes the sphincter of Oddi to allow the bile to enter in. So what is happening? The major mechanism, both, there is a local mechanism which is suggested by the release of the CCK binding to receptors on the gallbladder and binding to unknown receptors to the sphincter of Oddi. The other is that the CCK stimulates the sensory neurons, and these sensory neurons take the efferent reflex to the vagal complex in the medulla, from where the efferents come in and they stimulate the gallbladder and relaxes the sphincter of Oddi. The contraction of the gallbladder is by the action of the acetylcholine release, and causes the contraction of the gallbladder muscles, while the relaxation of the sphincter of Oddi occurs because of the neurotransmitters which are released by the vagal nerve, which is the nitrous oxide and the vasoactive intestinal peptide. Now, the formation, why bile is important, because one of the pathologies which you are going to see in practice is the formation of gallstones. And the most common type of gallstones which you are going to see in your practice during, if you are in GI or you are in general surgery, you would see the most common type of stones which you are going to see are in terms of gallbladder are gallstones, and these gallstones are mainly cholesterol stones. Now, these cholesterol stones are formed because there is an imbalance. There are three components of the bile which is stored in the gallbladder, and you know that the gallbladder bile is much more concentrated as compared to the to the liver bile. And the reason why it does not form stones, because you have a lot of bile salts there. If you have bile salts, the cholesterol remain solubilized, and if you have more phospholipid, again the vesicles would be formed. So, but if there is much more cholesterol produced and there is less amount of bile salts, then the cholesterol would become supersaturated, and that can lead to nucleation and then precipitation of cholesterol to form crystals. So there is an adequate balance between how much you have bile salts. If you have more bile salts, less cholesterol, cholesterol is going to remain solubilized and it will not crystallize or nucleate. But if you have an imbalance between bile salts and cholesterol, and there is less amount of bile salts and there is more cholesterol, that will lead to nucleation and crystal formation and more of the gallstone formation. So mucus glycoproteins, they help in supersaturation of cholesterol, while the lecithin, which is the phospholipid, it inhibits the nucleation and crystal formation. So if you have more phospholipid or you have more bile salts, there would be less amount of the gallstones formation. But if you have more cholesterol, less bile salts, and less lecithin, then there would be supersaturation of cholesterol, which will result in nucleation. And then once the nucleus is formed, more and more crystals are going to be developed and the stone formation is going to happen. The next diagram is showing you the same. There are three things. Phospholipids here, you would see on the base the bile salts, and you see more of cholesterol as you go over up this triangle. So if you have more of the bile salts here, there would be very little amount of the crystal formation. But if you go up here and you have more of cholesterol and less of the bile salts, as in this case here, you would have much more crystallization. If you have more of the phospholipid and less of the bile salts and less of the cholesterol, you would have more of vesicle formation. So in this phase, you have more vesicle formation. In this place where you have more cholesterol, less bile salts, and less phospholipid, you have more crystallization and more stone formation. And if you are going to go at this level where you would have more of bile salts and less of the cholesterol, you would have more of vesicle formation, which you would see. So what would be the effects of formation of gallstones? The gallstones can, block the cystic duct, which is the duct which is coming out from the gallbladder. So if that happens, bile still can go from the liver all the way down to the duodenum. So the only thing which is going to happen, because it is going to block the mouth of the gallbladder, there would be sludge, and that can lead to inflammation of the wall of the gallbladder, which is called acute cholecystitis. So you can have inflammation of the gallbladder and sludge within the gallbladder if the stone or the gallstone is basically closing the cystic duct. But there would be no problem. The bile salts would be still able to reach the duodenum because they are coming from the liver, and there would be no issues with the pancreatic enzymes. But if you have a problem where the gallstone is stuck into the common bile duct, then you would not be able to send the bile into the duodenum. And as a result, what would happen is that you would have two major things. You would not be able to absorb fat. So the fat is going to go into it would be excreted into the stools, and you would have steatorrhea. The other thing is that the bile also has this pigment which is called the bilirubin. So that would start to accumulate, and you would have jaundice, which is called the obstructive jaundice. The third thing which could happen is that the sludge will start to accumulate within the gallbladder, which can lead to and into the bile duct, which can lead to cholangitis, which is the inflammation of the bile duct, or it can also lead to cholecystitis because of the inflammation of the gallbladder wall. Now, there could be a consequence where the stones can obstruct the sphincter of Oddi. Now, if the stones are going to obstruct the sphincter of Oddi, then you have two problems. One, the bile is not going to go into the duodenum. The other thing is that pancreatic duct is also coming from here, and it cannot, the pancreatic enzymes cannot go into the duodenum. So again, you would have steatorrhea because you cannot absorb the fat. You would have obstructive jaundice because the bilirubin levels will go up, and this will lead to obstructive jaundice. The third important thing is that some of these enzymes, as the pancreatic enzymes, which are secreted as proenzymes, they would get activated and they would start to digest the pancreas, so that would result in acute pancreatitis. And further, the sludge can also lead to cholangitis and cholecystitis. So those could be the consequences of a stone which is obstructing the sphincter of Oddi. Now we are coming to the hepatic circulation, and we know that the liver, the blood flow to the liver is around 25 to 30% of the cardiac output. And liver is an expandable organ which could serve as a reservoir for the blood which is coming from the veins and sinuses. The other thing which you can easily think about is that, the inferior vena cava is going from the liver, taking all the blood from the GI tract into the inferior vena cava to the heart. So if you have a heart failure, especially the right heart failure, the blood will go back from the to the inferior vena cava and will start to accumulate into the liver, resulting in more of a congestive type of hepatomegaly. So heart failure can present with a congestive type of hepatomegaly. Uh, if you have hemorrhage, the blood can move from these organs where they are they are basically pulled in, and the liver can contract and expel the blood out because there's a hemorrhage which is going on. What you need to know is that after meal, the portal blood flow increases due to the metabolic activity of the GI tract, because most of the blood which is coming to the liver, 1300 ml per minute from the portal vein and 500 ml from the hepatic artery. So this is an oxygenated blood. This is a deoxygenated blood. But on the other hand, the portal blood is bringing all the nutrients into the liver. So both portal flow and hepatic artery flow increases due to the metabolic activity of the liver. So whenever you are eating and you take food, the blood flow to the liver is going to increase, both through the portal vein as well as the hepatic artery. Now there are three zones of the liver. One which is near, if you look at the hepatic lobule, there's a portal triad. Then you have the hepatocytes in the middle where the sinusoids are. And then in the center part, you have the central vein, which is going to open into hepatic veins and to inferior vena cava. So the zone which is near to the portal triad is the zone 1. And then you have the zone 2, which is the middle piece. And zone 3 is the one which is near the central vein of the hepatic lobule. Now, what you also need to know is that when there is cirrhosis of the liver, for example, and you have compression on the portal vein, or the branches of the portal vein, the pressure into this system is going to increase, which will allow the fluid to pass through these spaces in the sinusoids to go all the way from the surface of from the hepatocytes to the surface of the liver, and they would start to accumulate there, resulting in ascites. So one of the consequences of portal hypertension is that the fluid starts to accumulate into the peritoneal cavity by passing through the sinusoids of the liver, through the hepatocytes, all the way down to the capsule, and then accumulating into the peritoneal cavity. So excessive fluid accumulation into the peritoneal cavity is ascites, and this is one of the consequences of the portal hypertension. The other important thing is that you can see that the portal vein is formed by the splenic vein and the superior mesenteric vein. So if you have more pressure because of the cirrhosis of the liver, what is going to have that back pressure is going to cause the spleen to get enlarged. Then there are sites of portosystemic anastomosis. One of them is at the gastroesophageal junction. The other is in the posterior abdominal wall in the retroperitoneal region. Third site is around the umbilicus, and the fourth site is at the junction of the rectum with the anus. So these sites where the portal circulation is joining with the systemic circulation, there would be enlargement of the veins. So you would have esophageal varices at the gastroesophageal junction. You may have the dilatation of veins in the retroperitoneal collaterals. You would have dilatation of veins around the umbilicus, which will show like, they are coming out from the umbilicus like like a crown. So this is called caput medusae. Or you might have internal hemorrhoids because of the veins which are joining the branches of the inferior mesenteric artery with the rectal veins, which are part of the systemic circulation. So there will be three consequences of the raised portal pressure because of the cirrhosis. One is the ascites. The second is the enlargement of the spleen or splenomegaly. And third would be these varices. The most common among them is the esophageal varices. And because these submucosal veins, which get enlarged in the lower part of the esophagus, some of these patients presents by the rupture of these varices, which results in hematemesis, and they have a liver disease, and they present with hematemesis because of the rupture of the esophageal varices, which is present at the junction of the esophagus with the stomach because of the raised pressure in the portal vein, portal hypertension because of the cirrhosis of the liver. So you can see ascites here, which can happen because of the portal hypertension. Now, the other thing which you need to understand is that the zones which we have talked about, that zone one, which is near the portal triad, uh, it is the place where you would have more of the oxygen. It has higher oxygen pressure. So this is more resistant to any injury. While the zone three, where you have low partial pressure of oxygen and there's more of the anaerobic glycolysis happening. So this is the area which is much more sensitive to ischemia and also the drugs. So if you are going to, if you are affected by, ischemia or, a toxic drug, this is the area, the zone three is the area which is going to be much more sensitive with the toxins, and it is much more sensitive to ischemia as compared to this region. So any injury to the liver, you would first see it in the zone three versus zone one. So any fibrosis, any injury because of the ischemia or toxins would be much more in zone three of the liver as compared to the zone one. Now we are coming to the different types of cells which you would see in the liver. You would find hepatocytes, you would see stellate cells, you would see the Kupffer cells, you would see the endothelial cells of the sinusoids. So these are, and you would see the cholangiocytes, which are lining the bile caniculi. So these are different types of cells which you are going to see in the liver, and they have different functions. So the function of the hepatocytes is to form the bile by caniculi joining together with the bile caniculi. So the bile is produced by the hepatocytes, and it is secreted within the bile caniculi, and the cholangiocytes which line the ducts are the ones which are going to modify the bile. Hepatocytes have metabolic functions in terms of the bile acid synthesis, bilirubin secretion, cholesterol, phospholipid secretion, drug detoxification, metabolism of macronutrients. Uh, Regeneration also, the regeneration of the hepatocytes, because they secrete hepatocyte growth factor, so they are also involved in regeneration. The Kupffer cells are the resident macrophages of the liver, while the stellate cells have the function of storage of fat storage and vitamin A storage, but their function comes much more when you would see the injury to the liver, because they start to secrete, lay down collagen, which results in cirrhosis of the liver. The endothelial cells you would see here have gap junctions here, so there is free movements of several molecules through these gap junctions. There's no basement membrane, so these are highly permeable to proteins, these endothelial cells. This diagram is a little bit more complex, but I think it is important. We need to look at the metabolic functions and detoxification function of the liver, which includes the detoxification of alcohol, drugs, synthesis of the steroid hormones, non-steroid hormones, growth hormones, growth hormone, insulin, the metabolic function is there. There is production and regulation of triglyceride, phospholipids, lipoprotein, acetyl-CoA, cholesterol. It is done by the liver. Then there is, in terms of protein metabolism, you would find that non-essential amino acids, uh, functional proteins like clotting factors, transferrin for the transport of iron, lipoprotein for the transport of cholesterol, globulin for immune function, and albumin for oncotic pressure. They are all synthesized by the liver. So if you have a disturbed protein metabolism, you can lead to bleeding disorders because you are not making clotting factors. It can lead to excessive bruising because you are not making, essential proteins which are required. It can lead to ascites because the albumin is not produced and the oncotic pressure is reduced. It can lead to impaired immune function because globulin is not produced. It can lead to anemia and fatigue because you are not producing transferrin, which is important to transport iron. So protein metabolism, disturbed protein metabolism can lead to all these problems. The liver is also important in synthesis of bile, converts carotene to vitamin A, converts folate to 5-methyl tetrahydrofolate, converts vitamin D to active forms like 25-hydroxycalciferol, and converts ammonia, which is very toxic, to urea. It is also important in storing vitamin A, D, E, K, and vitamin B12. And especially if you have the deficiency of vitamin K, then you would have problems with the, clotting mechanisms. And it also stores essential minerals like zinc, iron, copper, and magnesium. It has a very important role in carbohydrate metabolism because it stores glucose in the form of glycogen. So it is an energy house. There are a lot of carbohydrate metabolism is happening, and then it is basically stored in the form of glycogen. And whenever you need energy, then the glycogen is broken down to glucose to get energy. And then the excessive carbohydrate is converted into triglyceride and stored. So it is mainly, if you take the liver out, there is no energy source which you have. So you need liver because it also is important in terms of providing, energy which is required. Now we are coming towards the bilirubin metabolism, and we need to understand that the major source of the bilirubin is hemoglobin. Most of the bilirubin is going to come from hemoglobin. The rest of it can come from myoglobin and other things. So the once the RBCs are degraded, the hemoglobin which is released is taken up by the macrophages, and the macrophages, separate the iron and globulin from the heme, and then it is within the macrophages, heme is acted on by the heme oxygenase to be converted into biliverdin. Biliverdin is then converted by the biliverdin reductase into bilirubin, which is released by the macrophages, and it is then bound to the albumin complex, and it is taken all the way to the hepatocytes. In the hepatocytes, this bilirubin gets conjugated to bilirubin glucuronide, and then it is secreted into the bile. And the reason why you see the yellow color of the bile, because you have bilirubin, which gives the pigmentation to the bile. Now, once the bilirubin reaches the intestine, it is again acted upon by the bacteria in the small intestine, and it is converted into urobilinogen. And this urobilinogen, most of it is going to be taken back through the portal system and circulated back to the hepatocytes, where it gets conjugated again and secreted into the bile. Some of it, this urobilinogen, is further oxidized to stercobilin and excreted into the feces, giving the brown color to the feces. The other thing which happens is that some of this urobilinogen goes to the kidney, get absorbed into the kidney, and is oxidized to urobilin, which gives the yellow color to your urine. So if you have excessive amount of bilirubin produced, or it is not excreted, then this bilirubin can go leak out from the hepatocytes and then into the blood, and then it can go to the skin and get deposited into the skin, giving yellowish discoloration to your eyes or your skin. So that condition, when you have yellow discoloration, that is called jaundice. In newborns, because the liver is immature and it cannot conjugate bilirubin. So in 60% of newborns, they have jaundice for transient period of time, for a week or 10 days, which is called the physiological jaundice, and it is because of the immaturity of the hepatocytes, because they don't have enough conjugating enzyme, and as a result they are unable to conjugate the bilirubin, which is coming to the liver, and you have jaundice or discoloration, yellowish discoloration of the skin and sclera, which is called the physiological jaundice. In adults, on the other hand, is it the two major causes of jaundice is either the excessive bilirubin production, which is because of excessive damage to the RBCs, because that's the major source of the bilirubin production, or defective bilirubin excretion. Either it cannot get conjugated, or it's not basically secreted from the hepatocytes into the bile, or there is an obstruction to the biliary apparatus. So we might divide this into prehepatic, which is mainly because of excessive destruction due to hemolytic anemias, or it cannot be conjugated in the liver because of the immature hepatocytes. So this is the prehepatic piece, or you might have the posthepatic, which is the direct type or conjugated bilirubin, where there is an obstruction to the biliary tree because of the gallstones or the tumor. Now, we can go into a little bit more detail of the jaundice. So jaundice is an abnormal yellowing of the skin or sclera due to excessive bilirubin deposition. Hyperbilirubinemia could be secondary to overproduction, as we said, or decreased disposition. That means it might be a problem in the impaired hepatic intake, conjugation, or excretion. So there are three parts in the hepatocytes. The hepatocytes are unable to take the bilirubin, or they are unable to conjugate the bilirubin with glucuronide, or they are unable to excrete the bilirubin into the bile. So these could be the reasons of jaundice. So this is an acronym which you can use very easily, which is called hot liver. So hemolysis, excessive RBC destruction, obstruction of the biliary tree by stone or tumor, or there is a liver disease. These all are the major causes of excessive bilirubin. So unconjugated hyperbilirubinemia, which is the prehepatic, could be because of the excessive hemolysis of RBCs, physiological because in newborns because of the immature hepatocytes which are unable to take this bilirubin, or there could be a problem in the conjugation, which is the Crigler-Najjar and Gilbert syndrome. Conjugated hyperbilirubinemia is the direct type. The most common thing is the obstruction of the biliary tract by gallstones or cancer, or there could be, biliary tract disease like primary sclerosing cholangitis and primary biliary cholangitis, which you would be learning in the later lectures with pathology. The excretion defects could be Dubin-Johnson syndrome or Rotor syndrome. We would just, in a minute, we'll talk about all these four syndromes, Crigler-Najjar, Gilbert, Dubin-Johnson, and Roters, because they have a problem. These are congenital abnormalities, which are either a problem of intake, conjugation, or excretion of the bilirubin. The mixed type, where you would see both direct and indirect hyperbilirubinemia, could be because of hepatitis and cirrhosis. So Gilbert syndrome is because you have a mild deficiency of this enzyme, which is the UDP glucouronyl transferase. So there is a problem in conjugation or impaired conjugation. But you would only have symptoms when you are under stress. You have fever or illness or infection, then there would be raised unconjugated bilirubin. So this is a congenital abnormality where you have deficiency of this enzyme, but you would only see symptoms when you are in a state of stress, like fever or infection, that your unconjugated bilirubin is going to go up. Crigler-Najjar, on the other hand, is a very severe problem. It will result in, it is because of the absence of this enzyme, and because there is absence of UDP glucuronidase, you are unable to conjugate bilirubin. As a result, unconjugated bilirubin levels are going to go up, and this unconjugated bilirubin is going to go and get deposited into the basal ganglia of the brain, resulting in a condition which is called kernicterus. So that is a very severe problem, and that can lead to death if we have no treatment like plasmapheresis, phototherapy. Transplant is the only option. So it's a very severe disease and it needs to be taken care of. Dubin-Johnson syndrome is more of a problem of excretion. So you have conjugation of the bilirubin, but you are unable to excrete it. The problem, there is more of grossly dark black liver. It's a benign condition. Rotor syndrome is similar, but it is much less, much milder presentation. You would not find any black liver in Rotor syndrome due to the impaired hepatic uptake and excretion. So this is the issue. If you have deficiency of this enzyme, which is important in conjugation, you would either, if this is mild deficiency, you would have Gilbert. If you have a complete absence, this will lead to Crigler-Najjar, which will result in increased level of unconjugated bilirubin, which will get deposited into the brain, leading to kernicterus. While 3 and 4, which is the excretion of the conjugated bilirubin into the bile, will lead to, because conjugated bilirubin is water soluble, so it will not go, it will not pass the blood-brain barrier, it will not get deposited. So the conditions which you are going to get would be the Dubin-Johnson and Roters, which will result in jaundice, but conjugated hyperbilirubinemia is not really a problem because it does not passes the blood-brain barrier and get deposited into basal ganglia, resulting in kernicterus. So the number 3 and 4, Dubin-Johnson and Roters, are basically benign conditions which will lead to conjugated hyperbilirubinemia. These are the signs of liver disease. So you might have effects of portal hypertension, which we have talked about, which results in esophageal varices and can lead to hematemesis. There could be gastric varices, which will result in blood mixing with the stools, giving black stools. You can see ascites. You can see caput medusae. Anorectal varices can happen. Uh, Steroid hormones are basically produced by the liver, and they are important in terms of cholesterol synthesis and steroid synthesis. So this can lead to, if you have liver disease, can lead to testicular atrophy, gynecomastia, amenorrhea because of the problems with the metabolism of the steroid hormones. You would see jaundice on the skin. You might see palmar erythema because the estrogen levels can go up, which will cause the blood vessels to dilate, and you can see palmar erythema there. You might see petechiae because of the clotting factors defect, which with small hemorrhages in the skin. There might be hepatic encephalopathy because one of the important things which the liver does is convert the ammonia into urea. So if you have the liver is not functioning, so you would not be able to convert ammonia into urea. And if the urea levels, ammonia into urea, so if the ammonia levels goes up, it would affect the neurons, resulting in hepatic encephalopathy and also flapping type of tremors, which are, estrexis, because you ask the patient to put your hands up like this, and then there will be flaps. So flapping tremors is also sign of high levels of ammonia in the blood. There might be, anorexia, nausea, vomiting. There could be a specific type of smell coming out because of high levels of ammonia, which is called feta hepaticus. Hematologically, you might end up with thrombocytopenia, coagulation defects, splenomegaly because of the raised portal hypertension, anemia because of the transferrin is not produced, so the transport of iron is affected. There might be hepatorenal syndrome happening. There might be metabolic effects because of hyperbilirubinemia and hyponatremia, and cardiovascular effects, which can lead to peripheral edema because you are not producing enough albumin. So there would be dependent edema because of the reduced oncotic pressure and those type of things which are happening. So these are all signs of liver disease because of some functions of the liver. You may also end up with spontaneous bacterial peritonitis, which is known as the primary bacterial peritonitis, common and potentially fatal bacterial infections in patients with cirrhosis and ascites. Often it is asymptomatic, but can cause fevers, chills, abdominal pain, IES, or worsening encephalopathy. Common organisms which are involved in spontaneous bacterial peritonitis are E. coli and Klebsiella. And diagnosis, how you do it is by taking a tap from the acidic fluid and look at the absolute neutrophil count. If the absolute neutrophil count is more than 250 cells, this is, spontaneous bacterial peritonitis. And the treatment option is the third generation cephalosporins. Now, there are markers which you can use to look at the liver disease. You have these enzymes like aspartate aminotransferase, which is the AST, and alanine aminotransferase, which is the ALT, which you can see. In most diseases of the liver where there is inflammation, their ALT is more than the AST. But alcoholic liver disease is, special, where AST is more than ALT, and there is 1:2 ratio of AST to ALT. If AST is more than ALT in non-alcoholic disease, this suggests that the progression towards advanced fibrosis and cirrhosis. Alkaline phosphatase and gamma glutamyl transpeptidases are markers for obstructive type of jaundice or cholestasis. So if there is obstruction of the biliary tree, you would find alkaline phosphatase and gamma glutamyl transpeptidase to go up. Bilirubin gives you, is it conjugated or unconjugated? That would help you to differentiate between obstructive or hemolysis in terms of the liver pathologies. Albumin in advanced liver disease, it goes down, and this results in edema because there is reduced oncotic pressure. Prothrombin time goes up in advanced liver disease because there is decreased production of clotting factors, resulting in inability of the liver to produce clotting factors. In advanced liver disease, platelet levels are also going to go down because there is decreased thrombopoietin and also destruction of the platelets in the liver as well as in the spleen. Hepatic encephalopathy, we have already talked about. It usually is one of the signs of cirrhosis where you are unable to convert ammonia into urea, and this overproduction or decreased removal of ammonia from the system can result in hepatic encephalopathy. It's a reversible neuropsychiatric dysfunction ranging from disorientation to astrixis, which is the flapping tremors, to difficult to arouse or coma. So in severe cases of hepatic encephalopathy, you can be in coma. The way you treat it is that you give lactulose, and which increases the formation of ammonium rather than ammonia, and you treat with rifaximin and neomycin so that the gut bacteria are going to produce less amount of ammonia. So you have to give lactulose to generate more ammonia, and you have to give antibiotics to decrease the bacterial conversion, bacterial production of ammonia, which goes into the portal system, because liver cannot convert this excessive amount of ammonia which is being produced by the gut to urea. And that's why this and the ammonia is going to affect the central nervous system, which will result in hepatic encephalopathy. Thank you very much. If you have any questions, I'm happy to answer them.
Thank you, doctor. There seems to be no questions in the chat.
Okay, thank you.